will have a very different T stage between the two diseases. Because of the small lumen of the appendix cancers tend to present with T4 disease, meaning they're already perforated and they've spread in the peritoneal cavity. Does it make sense?
Yeah.
Whereas with patients with colon cancers, you don't see that. It's more commonly T3, T2 lesions. These are the more common lesions, you understand? And the reason why I specify that is because if you look at it, that T2, T3, they in colon cancer, they focus on the nodal status. How many nodes do you have? So in fact, when you do a colon resection, they want you to have a minimum of 12 lymph nodes to be removed because that's how we stage patients.
Okay.
And the reason is because the risk is that of systemic disease. And systemic disease is very different from peritoneal disease. Systemic disease is disease that's considered stage 4, but it's in the liver, the lung, sometimes the skin, the brain, bones, other areas outside of the peritoneal cavity. The liver is in the peritoneal cavity. Understand that 80% of patients that have some kind of systemic disease with colon cancer, it's usually to the liver. Okay? Appendix cancer is very different. So appendix cancers do present with T4 disease, meaning there's usually extra peritoneal spread, meaning peritoneal surface malignancy is how we term it, but basically the abdominal cavity has disease associated. Now, when I look back at colon cancer, probably about 10% of patients will present with this manner. Well, they have a perforation and it's spread.
Okay.
But it's uncommon. It's usually the location has to do with the physical size of the lumen.
Okay.
Do I believe this is appendix or do I believe this is colon? It makes no difference. Because the reason is because the cellular type is still the same as an adenocarcinoma. And the problem is that regardless of what I told you here, your issue is not, this is not your problem. Okay, your problem is this peritoneal surface malignancy. It's this disease that's outside of the appendix that's in the peritoneal cavity. So the prognosis for this is very different. When we talk about systemic therapy and stage 4 disease, liver lesions is what we're talking about in this setting here. And the therapy is usually liver directed, meaning liver surgery, radiation, chemoembolization, ablation. That's what we talk about for liver-directed therapies.
Okay.
That's commonly for systemic disease. And the backbone of this therapy is a lot of times IV chemotherapy. It's very different for peritoneal surface malignancies. The prognosis for this is very different. As the disease progresses in the peritoneal cavity, it will give you a symptom called peritoneal carcinomatosis. It doesn't, not everyone with colon cancer or appendix cancer gets it. But if you have peritoneal surface malignancy, this is the thing that we worry. So if you look at this is the reason why we did IV chemotherapy because we believe it's systemic. We're trying to delay the development of liver disease. In peritoneal carcinomatosis, the problem is you basically have a lesion that's in the right side of your cavity, and eventually it will start spreading to the rest of your abdominal cavity. And when it does that, it will give you a symptom. So the first caveat is that the peritoneal carcinomatosis, you have to have intra-abdominal disease, right? And we know you do because at the time of the laparoscopic hemicolectomy, they found a spot, right?
Well, they found several.
That's right. I mean, I'm not saying they found spots.
Right, yeah.
Right? They found several spots. And the problem is that's what we can see with our bare eyes.
Right.
But I can make the assumption that you have more disease. That's the reason why you're on chemotherapy, right? If I could prove to you there was no disease there, then you wouldn't have to be on IV chemotherapy. Make sense?
Yeah.
Right? But that's the reason why you're on this. Remember, I asked you how many cycles does you want to do?
Right.
It's forever. It's infinite
Right.
because
Right.
we believe you have intra-abdominal disease.
Right.
The problem is at a certain point, the disease may become resistant to the chemotherapy, and or the disease is already resistant and will continue to progress. It just is at a level that's low enough that the level of cancer that you have is low enough that it's not giving you any symptoms. It has to reach a certain amount, and once it reaches that certain amount over time, that's when you have symptoms.
What kind of symptoms?
So that's what this syndrome of peritoneal carcinomatosis is. So typically it's a symptom of nausea, vomiting, constipation, diarrhea, loss of weight, abdominal distension. You may have ascites,
What is
okay,
that?
fluid inside your belly, cachexia.
What is that?
What happens is you gain weight from fluid inside your belly, but you lose weight in your arms and your legs. Okay, so the rest of your body is being absorbed by the cancer. And you can't eat. You have an inability to eat. Why? Because the cancer, what it does is it goes onto the lumen of your bowel. And when it does that, it makes the bowel thickened. Okay? And what happens is, the way the small bowel works is it has to peristalse, meaning it has to squeeze so that whatever food you have gets pushed forward. If you have cancer on it, it doesn't squeeze, it becomes a pipe. So what happens is some of the food will go forward, but some of the food will go backwards. And the problem is that's the reason why when the food doesn't go forward, you get diarrhea, you get constipation. And when the food does go forward very quickly, you get diarrhea. Because your body is trying to make the food go forward, so it will put fluid inside of it. And if it doesn't work out that way, then you get nausea and you get vomiting. Do you understand?
Yeah.
You don't have these symptoms, I'm not surprised.
She does.
do have.
Yeah, but you know what?
feel
But you had them from before, right? Before the surgery, before your laparoscopic hemicolectomy. When
Yeah.
someone has this, the loss of weight is also part of the thing. Like you said, you're not losing weight. This has a very, very, very poor prognosis, meaning that survival is measured in months, sometimes weeks, once you get to this point. Okay, and so when survival is measured in months, there is no therapy for this. Unfortunately, a lot of people are given IV chemotherapy, and the idea here is you're trying to slow the progression. So, if your disease is growing, without chemotherapy, it would have got it inside the belly was growing like this. The idea is that you're giving chemotherapy to either change the progression or trying to lengthen out the time that do you see what I'm saying? You're trying
Yes.
to change the curve.
Yeah.
But it does not treat it, meaning there is no way to reverse this. Once you've gone down this course, very little. And what we do is patients that are sent to me with surgery, cytoreduction and HIPEC, many times they have this and they're sent to me to consider this. This is still not a treatment for that. Once you have this, I can't remove the tumor from your bowel. If I can't remove the tumor from your bowel, neither this or this will work.
Why can't you remove the tumor from the bowel?
So the risk is a perforation to the wall, and if you leak stool and contents into
Right.
your bowel cavity, you'll die.
Why can't you just take out that section?
Doesn't work that way.
Tumor.
Because what happens is it may not just be that one section, it may be multiple sections. So here's an example. You have a balloon, that's your peritoneal cavity. If I blow it up and I put some powder in there, then I shake it around, do you think that those little bits of powder are gonna stay in one area, or it's gonna go all over the place? Right?
Okay.
So it's gonna go all over the place. So the risk is such that if you think about it, when you had perforation and you had peritoneal involvement, one can assume that the disease is throughout the abdomen. It's not just contained in one area.
Oh,
Okay,
okay.
and the reason why it may not show up on the CAT scan is the CT scan can see something that's maybe 1 to 2 centimeters in size. These things are microscopic. You're never going to see them. You're not going to see them until they're 1 or 2 centimeters. By the time you have something that's 1 to 2 centimeters, you got peritoneal carcinomatosis, too late.
Okay.
Okay, so the role of surgery in HIPEC is to try to do the same thing that this is doing. In fact, it's trying to get rid of the carcinomatosis, trying to get rid of these snail cells. But if you think about it, which more effective? Trying to give surgery in HIPEC on a lesion that's this big or a lesion that's this big, right? So it is, in a way, you're trying to prevent this from happening. You're trying to prevent carcinomatosis from happening. Just like IV chemotherapy is trying to prevent liver tumors from happening. When someone has a high risk for intraperitoneal disease, this is what you're trying to do. You're trying to do this to prevent this, because this is such a poor prognosis. The issue is that when you have these symptoms, you say you have these symptoms, but when this occurs, your quality of life will be much worse. Okay, because you have fatigue, you'll have it's not a very good way for patients to pass. Does that make sense?
Yeah.
Okay. But just like these, IV chemotherapy can't prevent all liver cancers from coming, liver tumors from coming back, the same thing. There's a failure rate for this. And the procedure for this is pretty hefty. So the more prominent your disease is, the more surgery you have. The more surgery you have, the higher the possibility of complications and the alterations in the quality of life and the decrease in the quality of life. So think about it. If you have, I have people that have very extensive disease, and I have, I'm just going to break it up. I have to operate in all 4 quadrants, okay, because they have all disease. That's very different from someone who has only disease in this left lower quadrant that I can see. So the surgery portion, for someone who's early, I may do less, right? But the chemotherapy is going to be done for the whole belly.
Yeah.
So it's for the same, right? But it's going to be easier for the patient to recover from this when it's early than when it's too late.
And where does hers qualify?
Well, my feeling right now, your CT scan doesn't show any disease. I mean, in my eyes, it shows a little bit of disease in the right lower quadrant, like where they did the hemicolectomy. Now the question always becomes, how accurate is the CT scan in predicting what the surgery? It tells me what I can't do. So when a patient has evidence for peritoneal carcinomatosis, ascites, mesenteric shortening. Mesentery is the blood supply to the bowel, the blood supply. When the cancer cakes onto it, it shrinks your bowel. It really makes it all central. So you can't disconnect it and put it together. That's part of the reason why you get the symptom. So when I see mesenteric shortening, ascites, or extra abdominal disease like liver mets, I don't offer that surgery. It's too late, really. For you, what I see on the CAT scan is a little bit of disease down here, but could you have more disease? Absolutely. So when it's obvious that I can't do the procedure, I would tell you I can't do the procedure. I would teach a little bit about this, but then I would say we can't do the HIPEC, and this is the reason. For you, you're early stage. I mean, let's be honest, your diagnosis was done very, very recent, and you have received chemotherapy. You don't have any measurable disease on the CT scan. You've never had measurable disease, and your tumor marker is less than 1, or it's 1, right? It's still low, okay? But everyone believes you still have disease. Does that make sense?
Yeah.
So it's interesting, right? So I see the procedure as a twofold thing. Number one, it will give you information as to how much disease you have at the time of the surgery. Okay? It will provide a volume of disease. The way we do this is actually when we're in the operating room, when we open you, because it's an open procedure, what we'll do is we'll divide your body into 12 areas. This is only 9, but 12 areas. And you're scaled from 0 to 36. 36 just means that you can't be, it's just cancer everywhere. 0 means that we don't see anything. And it's based on a size. Okay? People that do really well, they'll obviously have lower, this is what we call the peritoneal carcinomatosis index score. That index score, when it's less than 10, they do very well, because you know that you can resect all the disease, and the morbidity of the surgery, the quality of is lower. Where I can't do it is if it's above 20. When the disease is pretty extensive and I have to take out all these organs, patients don't recover very well. So when it's above 20, even though if I can do the operation, I don't offer it to them. Because,
that's after you've opened them up.
That's after I've opened it, yeah.
And you just stop, you
I had to
just put
stop,
it back
yeah,
together.
because of the risk of the surgery.
And then if that should happen, does that expedite the growth and the...
So the answer is yes. And the reason is because you can't get chemotherapy after you've got to wait 3 or 4 weeks before you can get back onto chemotherapy. And we do know that what's holding your cancer at bay is your immune system. So when I do surgery, it reduces your immune system. So your ability to fight this cancer that's the reason why there's a classic saying that don't let the air touch your belly, right?
Uh-huh.
That it's a true and unrelated. So the fact that when we open and you have cancer everywhere that accelerates the cancer, that's true. But it's not because air touches, air gets into your belly, but
that's interesting. Our father died from brain cancer, and that's
what they told us.
They opened him and the air got to it. and
No.
it was
No.
just a few weeks.
So what we understand about cancer biology is that your immune system is very important in holding back the cancer from continuing to spread.
Okay.
Okay, and what happens is when you do a surgery, you're basically now dividing the force of your immune system into healing from your surgery and fighting the cancer, right? So you know that if you're fighting a war by dividing the forces, you're not going to be as strong. You're going to get overwhelmed, and that's the idea. So it's true. Yes, I let air touch it. It's true that cancer spread, but they're completely unrelated.
Okay.
Does it make sense?
Um,
So for you,
do you have to quit chemotherapy for a certain amount of time before you do the surgery?
yeah, so typically we wait about 4 to 6 weeks. It depends on if you're on this medication called Avastin. The reason is because if I have to take out some more of your bowel, you have to heal that, right?
Mhm.
So we don't, so chemotherapy and radiation can mix, but surgery, chemo and radiation, surgery versus chemo and radiation cannot mix. So usually we have to wait. That average waiting was between 4 and 6 weeks. Before surgery and after
And
surgery.
after,
That's right.
okay, that's what I was gonna ask.
And that's for something like fulfilling. We'll wait about 6 weeks.
6 weeks.
Yeah. Now, here's my feeling on you. I've given you some information. Let me be personal. Part of the thinking of this therapy is always has to be personal. That's the reason why I'm going to make it personalized to you. If you believe that there's disease still inside of you, which I believe you do believe because you're still doing chemotherapy, because if you didn't believe it, then you wouldn't do chemotherapy, then you have to see surgery and HIPEC as a role for two things. Number one, it will gauge how much disease you have. If you have very little disease, you're going to get very little surgery. And that actually is good. It's a good prognosis for you. But the second thing is, if I can actually gauge the amount of disease in your belly and treat you within the peritoneal cavity as what we consider the standard for now, you could potentially get off chemotherapy. This is a way for you to actually get off of IV chemotherapy until you get another recurrence or something does occur. Do you understand? So the strategy for patients with peritoneal surface malignancies should not be IV chemotherapy until something happens.
Okay.
Does that make sense?
Yeah.
It should be something more invasive. It doesn't have to be this. If you want to, this is the strategy that we can employ for you. We already did the CAT scan. I wouldn't get you a CAT scan, no more imaging. What we'd do is, we would do laparoscopy. Put a camera into your belly and let me prove to you that there's disease there. If I can
have
prove,
pictures of the
Yeah,
disease
right.
that was left in there.
but that doesn't, but you've received therapy.
So you don't know if there's
okay.
still
You don't
I
know if
see.
your disease
I
there,
see.
right? You
Right.
received therapy, so you really don't know
Right.
really if there's disease there because your tumor marker's less than 1, CT scan, and you've had time. You've had time. There's no, I don't know. So let's say I do laparoscopy. If I can prove to you, I do a biopsy. Yes, you have disease, okay? But that disease is low volume. Then I should try to convince you to do HIPEC with surgery plus HIPEC, and I could tell you what we have to do. So that's one therapy.
Okay.
Okay? The second therapy that you could do is you just go straight to surgery and HIPEC. You say, yes, no, I believe that's there. I don't need to have laparoscopy. I want you to just do the therapy. Patients come to me that way.
Okay, so what's the prognosis?
There's no
or
difference. The prognosis-
percentage, or you're healing from 2, aren't you? If you
Yeah,
do
but the laparoscopy is just a small camera. You would have a space between 2 or 3 weeks. You wouldn't have any problem. I would say this. Let's say you do chemotherapy, you stop chemotherapy, right? 3 to 4 weeks later, I wouldn't wait to 6 weeks. We're just putting this camera in and looking.
Okay.
Okay, it's a low risk procedure.
Okay.
Then I can come to you and say, yes, you have disease or you don't. Because see, the problem here is I haven't proven to you have disease. Why would you commit to a huge therapy
Yeah.
until I've proven to you that you have disease? Okay. Some patients come into the.
So obviously, that's what
but-
you would recommend is a laparoscopy.
No, that's not what I'm just telling you your
I feel
options.
like
Those are the
I-
These are options.
Okay.
But see, but you say, oh no, I feel like I have disease there, so I just want you to do this. Do you understand?
Right.
That's some people. Some people, this is the third option, is they continue to wait. They want radiological or tumor evidence that there's disease until I commit to that. So you have 3 options. You can wait till it actually, till a recurrence occurs, that we can measure using non-invasive ways to commit to surgery HIPEC. Or you can be as aggressive as, you know what, I know there's disease there, I'm gonna do surgery in HIPEC. I don't know where your personal feeling is, and all three are acceptable. In my mind, all three are acceptable, because you know why? We've never done a real study comparing those. Now, there is a new study coming up in the Netherlands, in Sweden, Scandinavian countries, where all patients with T4 colon cancers, they're all getting HIPEC. Not surgery. They're proven, oh, they have disease like you. There's disease like this. They're all going to HIPEC. The question is, will it change the development of peritoneal carcinomatosis and their survival? We don't know that. That's the study. You understand?
Without doing the
Yeah.
surgery, you're saying?
Right, because it's so low volume. They said, oh, we cleared all the disease out, there's nothing there. We would do the HIPEC, and if there was disease there and it was resectable, we would clear that out and do the HIPEC at that time. Do you understand?
Yeah.
So that's an interesting study for me, because it
Right.
will help me determine what would be the best course of action. Should we just wait, and then when you have something reasonable that needs to be treated, then treat you? Because I told you that many times it's too late, they get peritoneal
Yeah,
carcinomatosis.
I thought you
But-
said.
But that doesn't always happen, right? And peritoneal
But that's
carcinomatosis is
the
not a
risk.
0-1, it's a range. Some patients may have some symptoms, so we're gonna go in to see if we can actually reverse usually doesn't work, but I just have to tell you what the prognosis is. I'm not a favor of a person that's wait and see. The reason is because you know the disease is there. I know you believe in it because you're doing chemotherapy. If you didn't believe that the chemotherapy, if you didn't believe disease was inside of you, two things. Number one, you wouldn't come up all the way up from Portland to come see me, okay? And two, you wouldn't be on IV chemotherapy,
You're right.
right? So in the back of your mind, you know the disease is there. So you're given an option, a possible treatment plan that can do two things. Number one, gauge the amount of disease you have there, and two, potentially eradicate it all. That seems like a viable option. The question then becomes, do you want to know that it's worth it for you first, or do you want to just go? That's the issue. So when I look at those three options, the first two are probably the most reasonable, the third one is not.
Right, that's how I would agree with that.
I was gonna say, if you do the wait and see, we're saying, then you are increasing the risk of really getting to the point
Right.
that no, you can't do
Right.
it.
But here's my counter argument. By doing number three, where you wait and see, you don't run any risk for complications from a procedure.
Granted.
Is
You-
there,
There are risks that are associated with this procedure.
Sure.
It's a big surgery.
A lot.
It's
It's
a lot,
huge.
right? It's a big surgery, right? So you can have risks. You may not get back to IV chemotherapy. I may not be able to clear all the disease out. You may have a complication from surgery that could give you a poor quality of life. The intention of the surgery is to do what I told you, which is potentially eradicate the disease, improve your quality of life, and gauge your disease. The gauging of the disease is almost definitive. If I open and look, I can gauge the disease. That's pretty accurate. But whether or not you have a change in the quality of life, improvement or worsening, I can't predict that. That's the risk you take. You don't take any risk with it. And so that's the reason why that's why I have to present all three. In my mind, as a person, you're very healthy, I think 1 and 2 are very reasonable. But if you're a person who's very sick, on oxygen, you just had a heart attack or a stroke, you broke your hip, you're at higher risk, then maybe 3 is better, because the risk of surgery outweighs the benefit that you can have. Do you understand?
Yes.
That's why the
Yeah.
options have to be, you have to know all 3 options.
Okay.
is there a possibility is another option, because you said something a minute ago that made me think, if you did the laparoscopy to look and found no disease,
Right.
to do HIPEC?
Just do HIPEC alone.
Uh-huh.
That's a possibility, yeah. No, what I mean by these things is it's what we first start out to.
Right.
Where that pathway takes us. So for example, laparoscopy, you don't have disease that I can measure there, I biopsy, everything is negative. Yes, I can do a laparoscopic in HIPEC, I can do that. I just don't know what the benefit will be. That's outside the standard of care, because again, there's a study going on in Scandinavia, but I don't know if it's true. Typically, I do laparoscopic HIPEC for patients for palliation. So for symptomatic
Palliative care.
So if you have malignant ascites, you're having to go into the hospital and get drained every
Fluid.
week to get drained fluid from your belly. every week, you have no quality of life. Every week you come in, you reaccumulate. So what we do is we do this, the HIPEC laparoscopically, drain the fluid, put chemotherapy and heat. It doesn't make a difference what the disease is. The purpose isn't to try to cure the disease. The purpose is to try to prevent them from having to come back to the hospital. It's 80% effective.
But doesn't it end up at that point eventually anyway?
No, it doesn't always. And so it depends on the patient's, well, how can I say this? Their comorbidity. So if you're a patient that, you're right, if they're having all this fluid, but they're also sick on oxygen, they can't tolerate general anesthesia, I wouldn't do that. But there are a subset of patients that look like you, but it just keeps on accumulating fluid. They want to have a better quality of life. They want to be able to travel. They can't travel because every week they have to get tapped. But they're able to eat, they're able to do things, they're having no pain except for when they have distension, so they have to keep on going into the hospital. So by doing this procedure, you don't have to do that. They don't have to have the discomfort of abdominal distension. Don't do it frequently, but it's just the HIPEC alone. Now, if the study from Scandinavia proves that yes, when patients have T4 tumors with microscopic disease with no evidence, and we do this HIPEC and it actually improves their outcome, their quality, I'm going to do it more often. Right? The laparoscopic HIPEC. But until that paper comes out, I can't recommend it.
Okay.
Okay, now my question is, let's say you choose number 1.
Yeah.
Okay. She's gonna stop chemo, basically you're saying 3 weeks.
Yeah. 2 to
Okay.
3 weeks.
So basically a loss of 1 treatment.
Yeah.
Okay. So then.
But it'll be, so loss of 1 treatment, and then the decision to go back onto treatment is based on what we find.
Right.
But I can already tell you that it is unlikely that I can't do the HIPEC.
Unlikely that you can't.
Right, so it's more, I'm sorry, I'm doing a double negative. We will most likely go to HIPEC.
You're pretty certain there's disease there.
Yeah,
is what
I'm
you're
pretty
saying.
certain that
Okay.
there's disease there.
So I'm gonna take it one more step now, okay? So let's say you've skipped your chemo.
Yes,
So it's been long enough that now you can have the laparoscopic.
Yes.
Okay? And yes, you find disease, okay? So then
we just go right into HIPEC, we do the surgery.
Then you do the surgery
And
and the HIPEC so that the time without chemo is shortened.
That's correct.
Okay.
Oh, as opposed to
As
the
opposed
6
to-
weeks if you weren't
right.
doing laparoscopy.
This many weeks before, this many weeks after, if you were choosing option number 2.
That's right. That's right.
Do you get what I'm asking?
Right,
Do
so
you
what
wait
you're
3
saying is that,
weeks?
what she took from number 1 was that I would be willing to do the laparoscopy within that 6-week waiting period, that 4 to 6 week waiting period. Because then you get to buy time, and so if it doesn't work out, we just switch to just doing IV chemotherapy. Do you see what I'm saying?
Okay.
As opposed to having to wait the full 4 to 6 weeks before we do any. It's like, so for example, you had it 2 weeks ago, so I would give it about 2 to 4 weeks before we do surgery and HIPEC. But within the 2 to 4 weeks, if you were interested, we could do the laparoscopy.
Okay. And when you do the laparoscopy, what I wasn't understanding is it like I sign something that says you find disease, you go right
No.
into the,
No, it would be a different setting.
okay.
It would be a
So
different
it's
setting.
really 2
And how long do you wait
surgeries.
in between those 2?
Probably 2 weeks.
So it's still the same period of time
It's the same
overall.
period, because
Same
I have to
period of
wait,
time.
I have to wait, because so the only benefit from doing the laparoscopy is that if I can't prove to you there's disease there, then it's gonna be a real quandary, right? If I've done everything biopsy like this, do you really wanna be on chemotherapy?
No.
Do you see what I'm saying? But the risk is that you could still come back. Remember, I just because I do laparoscopy and I take biopsies and they come back negative,
Right.
it doesn't prove to you you don't have disease
I
there.
know.
So but it helps you to understand that the volume disease is very low
So why wouldn't you go right
That's
into
why I was
the
saying do
HIPEC?
Right.
because I haven't
So it
proven
could
to
be
you you have disease there.
microscopic.
Yeah. See, but I don't know if it's so that's the thing. I wouldn't have any problem about doing laparoscopic HIPEC. I wouldn't do it right on that moment because the reason is because it takes time for the pathology to come back. I can't know
Okay,
immediately like that,
okay,
right? So the
alright.
information from the pathology will take time, like a week or so, to come back to make the decision should we go for it or not.
But if it came back negative,
Right?
we're saying you would still go forward if
I'm
I
not
said
sure.
I wanted
We'd have
you
to discuss that. That's the difficulty. That if you get to that point, you're really in a good name. Because let's be honest, I took biopsies of things that I thought were suspicious. They're negative. I didn't see anything else. Should we do HIPEC or not? That's then the HIPEC is really done. Should you do any therapy, or are you free of disease? Because I've already even done an invasive procedure to look for disease. See, so we're talking about a hypothetical situation. Do I believe this is going to be you? I don't think so, but let's talk about this hypothetical situation. You don't have a tumor marker that's positive. Your CAT scan is negative. I did laparoscopy and biopsies, they're negative. I did washings, they're negative.
What are washings?
I put fluid into you, wash your belly, take them out, we look inside the belly for any cancer. We don't see anything. What are you treating with the chemotherapy?
But isn't that just, I mean, it's
So you're saying this
a short period of time that you've got that chemo, the HIPEC.
It is. I'm
in
not
your
saying that
act-
you couldn't do the HIPEC. What I'm saying is that what am I treating with it? Because what you're trying to say to me is that all the stuff that I did, all of it is wrong. You basically, we did tumor marker, we did blood tests, we did CT scans, we did biopsies, we did washings, we did a procedure, and they all show you don't have cancer. Okay, all of them.
So how do you
So,
justify?
so you're,
HIPEC?
I'm.
That's how I'm looking at it.
Exactly,
How would you
right? See,
justify
so
it
how
to
do
the
I
insurance
justify,
company?
because you don't have evidence for
That you
cancer. I
need to
have not
have
had any evidence of cancer. So how do I justify giving you a treatment? That's like saying that I'm gonna give him chemotherapy, because he may have cancer in his belly.
Right.
I'll tell you that if I did all this stuff inside of him, and it came up with the same results, why would I give him chemotherapy and you not chemotherapy, or give you chemotherapy and not him? Do you understand?
Yeah.
So what I'm saying is that the laparoscopy is giving you information as to deciding what the therapy is. That's the difference between 1 and 2. Is 2 it says, I believe so strongly that there's cancer there. I don't have evidence for it. I mean, I believe the CT scan suggests it, but I can't prove it to you.
Well, I would look at it as what I would feel like if it all came back negative. Hey, that's super, because that means it's really low.
So let's do the
HIPEC, and then
I don't disagree
got
with
a
you.
good
That's what that
shot.
Scandinavian study is doing, right? They're doing T4, they're saying they don't see any disease, and they're trying to prevent this from happening. It's the lowest volume disease, let's do it. But I'm just saying that's an experimental study. It's an experiment.
So
So-
you're saying my insurance
No, I'm not saying that.
wouldn't cover it if
So the
you-
answer is they may not cover